and we have a number of very esteemed faculty here today, so I'll just let everybody go ahead and introduce themselves. We could start with you, Dr. MacArthur. It's going to be hard for you to reach that mic.
This is a very big panel. So my name is Heather MacArthur. I'm the clinical director of breast cancer at UT Southwestern in Dallas and the Komen Distinguished Chair of Clinical Breast Cancer Research. Thank you.
Hi, I'm Mary Cianfrocca. I think you met me this morning. For the purposes of this panel, I'm a breast medical oncologist at City of Hope. I'm switching hats again.
Hi, Joyce O'Shaughnessy, breast medical oncologist, Baylor in Dallas, Tex Oncology.
I'm Rachel Lehman. I'm breast medical oncologist at MD Anderson.
Matthew Ellis, my most recent academic job in breast cancer oncology was at the Lester Institute's Breast Center at Baylor College of Medicine. Then I helped AstraZeneca develop drugs for a little bit, and now I'm developing breast cancer tests, so you can talk about that.
Mark Pegram, medical oncology, Stanford University in Palo Alto, California, where I'm a medical director of the Clinical Translational Research Unit and Associate Dean for Clinical Research Quality.
Tanya Gupta, breast medical oncologist and clinical assistant professor at Stanford.
Chirag Shah, outnumbered radiation oncologist and co-director of the breast program at the Cleveland Clinic.
Frank Piccini, radiation oncologist in Michigan.
Tom Buckles, I'm a breast cancer radiation oncologist in San Diego.
Hi everyone, I'm Nerea. I'm a third-year fellow at the Cleveland Clinic, incoming breast medical oncology faculty at Ohio State. And this is a 32-year-old healthy premenopausal female. She has a pathologic T2N2. We'll talk about her whole story in a moment. But really, what we want to talk about is adjuvant therapy in a premenopausal woman with high-risk early-stage breast cancer. So she originally presented because she felt a mass in her right breast. Initially, she didn't think much of it. Then over time, it became more painful. So at that point, she said, you need to have this checked out. Her performance status is great. Again, she's an otherwise healthy 32-year-old young lady. So no real medical history, social history also, never smoker, does not drink any alcohol, no illicit drug use, no family history of cancer, like moms, aunts, everybody lived well into their 80s. Again, no family history of breast cancer.
And could you give us a little bit of family planning history? Does she have children? Is she interested in a family?
Yeah, that's a great question. So she does not have any children, but she would like to have children. So when she underwent imaging, as you can see, she has multiple lesions in her right breast. The largest one is 3.7 centimeters. That was followed by an ultrasound. Similarly, the ultrasound showed that she had multiple irregular masses in the right breast. Again, there was at least 3. That was also followed by a right axillary tail ultrasound, which showed a cluster of irregular masses in the right axillary tail, which again were highly suggestive of malignancy. And so again, to take a better look, we did get an MRI of her breast. As you can see, those lesions are pretty obvious. Largest dimension on the MRI was 4.5 centimeters. I will say clinically, it seemed like it was above 5 centimeters, but again, based on the MRI calculations, it was about 4.5, multifocal, multicentric. There was no abnormal enhancement of the skin, nipple, or pectoralis muscle. And going back to those axillary lymph nodes on the right side, it seemed like it had been extending into the lateral margin of the pectoralis muscle. And based on our discussion with the radiologist, it seemed like it was going to be pretty difficult to get an ultrasound-guided biopsy based on the location.
So what would the panel like to do at this point to kind of clarify her nodal status prior to surgery? Is there any additional workup you want to do with that?
All right. That's skin thickening. You see it down, it's like a thin little speck on the right hand side of the image, to the left next to the tumor. It looks kind of thickened.
I think with respect to your lymph nodes too, it's very important. Doing an ultrasound-guided lymph node biopsy is almost universally available to be done. I would also use use ultrasound to stage the infraclavicular space, which is very uncommonly done. It's done in Houston, but obviously it changes the clinical stage then to EN3 disease. And at Anderson, they also use it to look at internal memory lymph nodes, and they even do FNEs that involve IM nodes too. So I think this would be a case that most likely would go on to neoadjuvant treatment, and having information about the extent of her nodal status and the time of pre-treatment is very important.
But the one comment I'll make is the skin worries me as well. In reality, I probably saw this patient because it's my clinic. So the one thing that has changed in the NCCN guidelines, which I don't know how it got in there because there is no data to support this in my opinion, level 1 data, but it says if you have clinically 1 or 2 involved lymph nodes, you can apply Z11 Namros, which is, with all due respect to BS, there is no randomized trial that included those patients. But people are doing it all the time. So if this was a patient who had a T2 tumor, no skin concerns, it was ER positive or HER2 negative, I've seen a lot of surgeons get them straight to the OR based on this NCCN guideline, but it's devoid of data. I don't know where it's coming from. People are like, well, it's close enough, and like it's really not. But this is the situation where the guidelines sometimes are inconsistent.
I saw these 3 nodes clinical staging there. So
yeah,
she's clearly got nasty.
She's got bad disease. Yeah,
got bad disease. Yeah.
And once in a while, the only thing we do run into sometimes with the radiologist is if the node is close to the vasculature, they will sometimes balk at that. And in that case, it depends on who you ask, but you can sometimes convince an MSK radiologist to do it if a breast radiologist won't do it. You know, I've done that before in some cases. The only thing we can do if you really can't biopsy, which is pretty uncommon, is we'll sometimes get a PET scan just to see if it has uptake.
We do FNA.
Yeah.
One of the last thing I would do was systemic staging because the nodes may be irrelevant. She has distant metastasis at this point.
She did actually have systemic staging, and there was no evidence of metastatic disease. So ultimately, she did undergo the breast biopsy, which, as you can see, did show she has invasive ductal carcinoma grade 2. And both of those lesions that they biopsied, they were ER positive, about 60%, HER2 negative. So clinical staging was stage 3A, so T2N2.
All right, so I believe we are calling her N1 based on the imaging, but there didn't end up being a biopsy of that lymph node. So at this point, with the information that you have, premenopausal woman that we are assuming is node positive, is anybody wanting a genomic assay to make decisions regarding adjuvant therapy, or are we ready to go ahead with chemo? Would we like chemo first, surgery first? So go ahead and give us your thoughts there.
In a premenopausal woman with T3N1 disease, I would give her chemo.
Agreed. And I think probably the area of discussion I'd love to hear what others would do is getting people's thoughts on Keynote 756, and would anyone with the data we have so far, still very early, consider that here, if treating neoadjuvantly, that is.
So,
I'm on the steering committee for 756, so I can speak to that, I guess. And it's up to you, Joyce.
I'm a bit.
Keynote 756 was the high-risk estrogen receptor positive, so not hormone receptor positive, but estrogen receptor positive, high-risk stage 2 or 3 population that was randomized to receive neoadjuvant chemotherapy plus or minus pembrolizumab, sort of in a similar 522 fashion, and then they go on to receive adjuvant pembrolizumab that they're assigned to that. We presented past CR data to date, so it is a co-primary endpoint like Keynote 522 did with event-free survival, so that is not yet mature, so we haven't presented event-free survival, but the improvement in pathological complete response, somewhat surprisingly to me at least, was 8.5%. If you look at the third interim analysis for 522, yeah, which was 7.5%.
Eligible though, because you had to have grade 3 disease. Actually, I had a lot of patients that couldn't go on that schedule.
for 756, but for the Checkmate 7FL study, which was essentially the same study, but with nivolumab as checkpoint inhibitor, they had an allowance for grade 2 disease, so a little bit different in terms of eligibility criteria, with a 10% improvement in pass CR rate with the nivolumab study, but no co-primary endpoint for that. Originally, it was designed for the co-primary endpoint, but along the course of the study, when the monarchy data was reported, which I think we'll touch on probably next, but a decision was made by the nivolumab team to drop the event-free survival co-primary endpoint and just stick with the PCR endpoint.
You know, the challenge, according to Cortazar's meta-analysis, looking at the association between PCR and time to event outcomes, is that it was most significant for triple negative and HER2 positive disease and not significant for hormone receptor positive disease. So you would have to have a very large, well-powered study, I bet, to detect an event-free survival benefit here with an absolute difference of only 8% in ER positive disease.
Yeah, but in 522 patients in different they are still benefited in a certain group. Right? So that's one thing I say. The other thing is, it sucks. And it sucks because we don't know what the driver of this tumor is. And that's why all we have is non-specific therapy. We're logging the toss about non-specific immunotherapy. This lady has a driver that's not diagnosed. And so, call to action, all the fellows in this room. Let's do studies where we can solve what is driving this cancer. Because she's not going to do well, because we've not made an adequate diagnosis. Right?
Yes, understanding disease, and we're just going to throw everything at her.
Yeah, you're exactly right. Yeah.
Neoadjuvant chemotherapy.
I'd say the chance of metastatic disease in 10 years is about 80%. Right, despite everything you're doing, would you agree? So I think there's a call to action in these kinds of cases. Young woman, it's like that patient I was talking about, was a trained rate, this is some other situation that we need to do here. And it's not biomarker driven. There's nothing clever about what we're discussing. We need to do a better job. So the young oncologists out there, make sure that these patients get studied, make sure we grow them in mice, make sure that we get them sequenced, make sure you talk to someone with a mass spectrometer and measure all the proteins in the tumor. We can do a lot better than the discussion we're having
That's
right
the
now.
conversation we have with every patient, right? That we know that population statistics look better, but we never know on an individual level who's benefiting, but with other patients, they get them until we get that insight.
So is, keeping in mind that this is a patient who is interested in a future family, is anybody nervous about delaying chemo for egg harvest? Or do we have some data to make us feel comfortable with a little bit of delay in order to be able to allow her to be well in the future?
You're not nervous. It's a really bad disease. I have to be very.
What do people about ovarian suppression now as a way to assert the ovaries? Is that still something you don't talk about? Yeah, that's what I do.
And I think from a data standpoint, I think Lambertini brought data to San Antonio a couple of years ago or something. And, he did show in large population studies that taking that 4 to 6 weeks for egg harvesting, et cetera, didn't adversely affect outcome. You always worry for individual patients, however.
Yeah, and this, those are probably not stage 3 patients by and large.
Right. Also, I think we, just from the chatter among the panel is I think that most of us would have favored a neoadjuvant approach on her, and she would have had systemic therapy earlier than she's going to get it by definition because she went for surgery and is going to need to recover from her surgery, etc. So delaying it even further to do it retrieval, I agree with you. It would make me anxious.
I think I don't think it's even an option to go with surgery first. I wonder what the thought process was there. You could alter your axillary.
It'd be interesting, Tom, to your point about, really knowing what lymph nodes are involved. It'd be interesting to know what systemic staging she had, whether she had a PET CT or whether she had a CT chest abdomen pelvis, the bone scan. Because I have had patients where the PET CT picks up a lot of lymph nodes that you did not expect on other, because they're not enlarged. They light up, but they're not enlarged. So they give you a better, in my opinion, a better view of what's going on.
But some surgeries, now this is a very high-risk situation, but say she had 3 positive lymph nodes, that she could potentially get a great response to neoadjuvant treatment and have a targeted axillary dissection and avoid the lymphedema that she's going to be stressed with because of a full axillary dissection and full radiation. So there are a lot of advantages medically. You're eligible, and again, a person like this clearly will be eligible for a clinical trial if she has significant residual disease post neoadjuvant treatment that now we don't know about. So there are a lot of advantages I see to doing systemic treatments first.
Yeah, the other comment I'll make is for patients who need a dissection, they push very strongly for something called lymphovenous bypass. So doing neoadjuvant therapy is nice for that as well because it lets the surgeon basically set up for a sentinel, and if it's positive, it's already set up to have an ALND and a lymphovenous bypass. That's been shown to drastically reduce the risk of lymphedema post-ALND with or without radiation therapy. Yeah, so a radiation oncologist discussing microsurgery is always a good explanation. But really, what it is it's a procedure, and there's a simpler forms of it. But the lymphovenous bypass is basically they do it after the dissection, and they do reverse mapping. So they're kind of putting a tracer in both ways, and then they go under, they put loops under the microscope, and the plastic surgeon will actually connect the small lymphatic channels into the veins. And they count how many anastomoses they're doing. I mean, these anastomoses are the size of the tip of your fingernail. So not something you can use like a chicken's foot to practice on like we did when we were in med school. These are super fine, and then they can actually follow them. And so our practice has done a fair amount of work with that and showing that the rates of lymphedema are very, very low.
So it's just funny, factors back in, so
yeah.
Higher up.
Yeah. And you can do it prospectively, like in patients who are having dissection. And also, some centers will do it once it develops as well. And so there's different options for these patients who are progressing with lymphedema, which is a major toxicity in a case like this.
I'm gonna get you a baseline status. Do you guys use SOZO, BIS, or do you use tape measure?
Yeah, so we typically use SOZO in our clinic. So we have one right next to the scale, and I share a clinic with the breast surgeons and the med oncs and the plastic surgeons that have portable bioimpedance devices they carry around with them because they go to different offices. But that's typically how we follow them. But there are other options as well, things like barometry, tape measure, things like that.
If this was someone with let's just make it simple, T2, so let's say a 3 or 4 centimeter N1 tumor that got neoadjuvant therapy and is a complete response in their axilla after mastectomy, would you default prescribe radiation in that patient?
This is the B51 question. And, yeah, you asked the right question, maybe to the wrong person, but I think B51 is a garbage study. I'll explain why it's a garbage study. It's because it was powered poorly. Matt discussed this, but it was powered for a 4.5% difference in invasive breast cancer free. That's just not going to happen with a regional nodal treatment. So you've set the trial up to be negative from the jump by making the margins such that it's impossible to actually show that difference. I mean, if you think about MA30, which was published, MA20, which was published in the New England Journal, looking at regional nodal, the benefit was great. It was large, but it wasn't anywhere close to 4.5%. And that was in non-biologic responders. To power a trial for a bigger difference in a group that already had a biologic great response, that was going to be destined to be a negative trial. I think the other thing that comes out of this is taking interval reports and turning them into gospel. People are already using B51 clinically. It hasn't been published as a manuscript. That's really not a great idea, especially with short follow-up. You think about a lot of these patients, they're still at 5 years on endocrine therapy, and as has been a lot of those recurrences happen in years 5 and beyond. And actually, I worry, I mean, most breast radiation trials, we don't consider anything dogma until 10 years. You don't see the survival differences with radiation until 10 or 15 years. You know, a lot of people say, what about N1 disease? Look at the Lancet paper that came out 4 months ago in the Lancet. 14,000 women studied with nodal disease, the benefit of radiation, and overall survival advantage in N1 patients of 3%. Took 15 years to show that. But this is where using short-term follow-up studies is, in my response, like irresponsible almost. And the last thing I'll comment is local regional recurrences matter. And there's already a trend, despite there being only 50% of the planned events, in difference in local regional recurrence. It's a P of 0.08 already, and you only have half the events you're powered to show, and that number of events is already not enough based on what I said before. So B51, it doesn't really change anything for me, frankly speaking. The only thing I'd like to see is that the response was no different based on biologic subtype. So everyone who responded had basically the same, because there's always been that one question is, would the biology, would the receptors change what you think? But B51, in my opinion, is nothing new and nothing important, at least at this day and age, to inform us of my decision making.
And I guess just for this case specifically with ER positive, I think those considerations are not as relevant as in ER negative or HER2 positive cancer, just because the chance of clearing those lymph nodes and having a PCR are so small. It could happen, but it's unlikely.
Just in a little defense of the NRG shot, say that the ER positives, they needed a longer follow-up. They do, to make you feel a little better.
And I sit on the NRG breast core committee, just so you guys know. I'm not sitting here bashing something I'm not a part of, but I think people are really rushing to this, and I think, I got calls the first week after the San Antonio abstract, it's going to pump the brakes, like, it's not ready for prime time, it's not even ready for part-time, like, I won't change our care path at Cleveland Clinic at this time until there's long-term data with the number of events. One, it's got to be published, and two, it's got to be published with enough events. Like, I don't think you can say a trial's negative when you're not at only 50 or 16% of the events that you plan for to show a difference. That's a rush to judgment, in my opinion. I don't think we would do that, at least this is my radiation club. I don't think we would do that with a new systemic therapy. We would say, oh, we want the follow-up for the events. We wouldn't throw that systemic therapy in the garbage if they only had half the events, if they started seeing differences. I think it's very easy as a breast oncologist to sometimes see radiation. I always say this, and this is beyond my soapbox. All the endocrine therapy de-intensification trials are focused on omitting radiation. Most of my patients probably have 5 fractions of breast radiation and 5 years of an AI. But yet the powers that be tend to keep running the same trial over prime to 90 to 40 BR007. So I think we have to think about it through the lens of kind of all the specialties when it comes to radiation therapy for some of these cases.
And just for completeness, I may have missed it, but did she have germline genetic testing?
Sure.
Yes. Yeah.
So I'm sorry we're running a couple minutes over. We will finish up the case and then just ask the panel to talk about organic adjuvant.
Yeah, so the details specifically as to why she went to surgery first are unclear to me, but she ended up getting a right radical mastectomy. As you can see, the pathology showed that she had 45 millimeter tumor left, and then 6 out of the 15 lymph nodes that they tested were positive for disease.
So that's probably a modified radical mastectomy.
Modified, yeah.
Which is not removal of the pectoralis major muscle. So just a point of clarification, I guess. Radical mastectomy is one of the most disfiguring type of surgery, if you could see it. Probably no longer done anymore.
So what would, first of all, which type of chemo is everybody going to be using in this patient, and then what other adjuvant therapies would everybody want to do afterwards? Sure, whoever wants to go first. First, with the chemotherapy, which type of chemotherapy is everybody choosing for her?
It's what's called the kitchen sink patient. Anthracycline and taxane, based on the
ABC.
ABC by the
Tic-tac.
Tic-tac thing.
I think we'd all give her ACT, abemaciclib, LHRH, AI, zoledronic acid. This is the kitchen sink.
Yep. And then just thinking about, again, kind of going back to that whole family planning piece and the data that we got from the positive trial. If she's 2 years in and she's telling you she wants to come off endocrine therapy to get pregnant, what is the answer from the panel? Okay.
We've already talked about the pattern.
And the positive was grade stage 1, 2 patient mostly, yeah.
I think there was only 7% of patients on the trial were stage 3, so not well represented.
We have consensus to give her post-mastectomy radiation.
Yeah.
Oh, yeah.
Oh, yeah.
using, anybody ever using protons?
Oh, God. Yeah, protons are an answer in search of a question. I mean, I think at the end of the day, there's a study going on looking at that. That's the RADCOM trial comparing protons to photons. And the idea is to look for toxicities. And not that I want to be a physics lecture, but the idea is that the protons may reduce the cardiopulmonary toxicities. The problem is it's a bad trial. Again, it allows an average hard dose of 14 gray, which if any of us give a hard dose of 14 gray, Tom and Frank were kicking off the stage if I ever let a patient get 14 gray. The national standard is under 4. So again, a poorly designed trial and that gives you the outcome you want is not worth the paper it's printed on. So, at this time I tell patients protons for breast are experimental. The studies from Dana-Farber and Maryland have shown more skin toxicities. Though with the use of intensity modulated proton therapy, we may see that therapeutic index that was alluded to before actually may improve such that the costs and the benefits outweigh that, but we're still trying to figure that out.
One thing that I think she should have done, I don't know, I can't remember if it's left or right, it doesn't really matter whether you're treating multiple fields, is to deep inspiratory Rutherford radiation, which really decreases the volume of heart in the field, more so than protons. And it's readily, should be available in almost every practice, I would think.